care and addiction medicine at San Francisco General Hospital. She is the director of the UCSF Health and Human Rights Initiative in the Institute of Global Health Sciences, a program that provides forensic medical evaluations for immigrants seeking humanitarian protection, and co-leads the National Asylum Medicine Training Initiative. Dr. DeFries has been instrumental also in our quality improvement project last year on screening for alcohol use disorder in post-liver transplant patients. And I'm excited that we have the opportunity today to learn from her expertise on alcohol use disorder.
Thank you so much, Lisa. Thanks so much for the opportunity to speak with you all this morning about alcohol use disorder. I have no conflicts to report. And today we're going to move through a couple different parts of the talk. First, we'll touch on alcohol use in public health, and then specifically in GI and hepatology, talk briefly about how alcohol works, how to assess and treat for alcohol use disorder, how to use a harm reduction approach, and then we'll touch on collaboration between hepatology and addiction medicine to really integrate the treatment of AUD into the care of all of your patients with alcohol-associated liver disease. And as we start, I just want to ground us in these terms that we can all use and all teach to help reduce stigma related to alcohol use and substance use that's so prevalent in our society and especially in our healthcare system. And really, stigma remains one of the greatest barriers to treatment of substance use disorders, including alcohol use disorder. So you're going to hear me use these sorts of terms during the talk, and I'd encourage you to try to adopt these if you haven't yet. You'll hear me use the word alcohol use disorder instead of alcohol abuse, a person with an alcohol use disorder using a person-first terminology instead of alcoholic or addict, person in recovery, alcohol-associated liver disease or hepatitis, medically managed withdrawal instead of detox, and recurrence or return to use rather than relapse. So encouraging people to use person-first language that is clinically accurate when we talk about alcohol use disorder. And so first, we'll discuss unhealthy alcohol use in public health. And I'll share with you one of my favorite graphs, which is from a study in the UK about the relative harms of different substances. And you'll see here that alcohol actually ranks most highly when they look at its costs in both individual level health and also healthcare and a higher level social costs. And when compared to all drugs, you see that alcohol has actually been ranked to be most harmful, causes harms to the user as well as others. And, you know, this is really something to reflect on, given that alcohol is probably one of 2 or 3 legal substances on this list. And unfortunately, you know, there's been a lot of studies recently to really characterize the enormous burden on mortality and morbidity that unhealthy alcohol use has in the United States. So here is a cross-sectional study from 694,000 deaths from 2015 to 2019. Note that this is pre-COVID times. And this large study of a cross-section of death records in the United States using national mortality data showed that 13%, that's 1 in 8 of annual US deaths attributable to excessive alcohol use. And then when we look at our state in California, 1 in 4 deaths among people between 20 and 34-year-olds and 1 in 5 among people 35 to 49-year-olds have been attributable to excessive alcohol use. So this is just an incredibly burdensome disease, and it's really impacting so many people in productive years of life. And other studies of mortality data really note increases in deaths among women, American Indian, Alaska Native individuals, and really emphasize the role of liver failure amongst younger age groups. Most of us know now that COVID-19 really changed things when it comes to the harms of alcohol use in our society. There were several studies now that have reported increases in drinking levels and transplants and emergency department visits for alcohol withdrawal. And here is another study of US mortality data that show how alcohol-related deaths rose during COVID-19. And how are we doing in San Francisco? Well, here is some health indicators related to alcohol from our local San San Francisco data. And the thing that I take away from this is how alcohol-related deaths and acute deaths all rose, and treatment admissions fell with the timing of the pandemic, and that they really have not returned to pre-pandemic levels. And with increases in AUD, we've also seen increases in ALD. The COVID-19 pandemic has led to an increase that's been documented in alcohol-associated liver disease, and ALD is now the leading indication for liver transplantation in the United States. And that has replaced hepatitis C, metabolic dysfunction-associated steatic liver disease, and is a leading diagnosis among liver transplant candidates. So certainly something really at the forefront for all of you who are practicing GI and hepatology. I never really learned how alcohol itself works until later studying addiction medicine. So we'll just touch on it very, very briefly. And unlike other drugs that are more targeted and specific, alcohol has really widespread effects throughout the brain, and it exerts its effects through the dopamine-mediated reward pathway. Alcohol also interacts with several other brain neurotransmitter systems, including the opioid system, the GABA, acetylcholine, serotonin, endocannabinoid, glutamate receptors, and there's really a variety of neurochemical targets that have been used as targets for medications tried for alcohol use disorder. And I just want to highlight that because we're going to talk about some of these medications in more detail today. During intoxication, alcohol exhibits a GABAergic effect. And then with chronic use, GABA is downregulated and glutamate via NMDA receptors is upregulated. And so in withdrawal, GABA inhibition's decreased and the glutamate effect is increased. And this really leads to the excitatory symptoms of withdrawal. And again, these are the neuropharmacological targets of medications for alcohol withdrawal and for AUD that we're going to talk about. And alcohol is associated with such widespread effects in the body, both physically and also psychosocially. It's associated with some of the most common conditions that we see in the primary care clinic where I practice, like hypertension, diabetes, depression. And these have all been found to increase with higher levels of alcohol use in a dose-response fashion. And even moderate alcohol use is carcinogenic. It's been associated with increased risk of nearly every type of cancer. And so alcohol is quite unique in how it affects so many different organ systems. And we're going to specifically today, obviously, focus on the liver system. So how do we assess for unhealthy alcohol use? Well, in the United States, lifetime exposure to alcohol is quite high. Nearly 86% of the US population reports using alcohol at least once in their lifetime. But only a portion of those people who use alcohol go on to have riskier use, binge use, heavy use, problematic use. And so most people who consume alcohol do not meet criteria for unhealthy alcohol use or alcohol use disorder. And you're hearing me use this term, unhealthy alcohol use, and it is an umbrella term that we're going to talk about. And it's important to recognize that unhealthy alcohol use occurs on a spectrum. And so it ranges all the way from risky use or problematic use to substance use disorder, alcohol use disorder, as consequences grow more severe. But unhealthy alcohol use is really the elephant in the exam room. There have been recommendations for universal screening of adults and pregnant people since the 1980s by the USPSTF to screen for alcohol use disorder in primary care settings, but only 1 in 6 report ever having been asked about their drinking. And so really this still remains something that often goes unaddressed. And how can you actually screen for unhealthy alcohol use in a sort of effective and efficient manner? Well, there's one question, it's called the single question screener, that you can hold on to. And a standard screening approach, it uses the single question screener of how many times in the past year have you had 5 or for men, or 4 for women or people over 65, or more drinks in a day. And this particular question has good sensitivity and specificity for detecting unhealthy alcohol use in US primary care settings. And to follow up a positive screen to that question, you can use a tool like the Audit C. And the Audit C is 3 questions that identify who is likely to have AUD and to benefit from treatment. And this has been abbreviated from the Audit, which is a 10-question tool used by the WHO. And it really asks just 2 basically additional questions to quantify and characterize people's drinking. And if they have a score greater than 4, then they likely meet criteria for alcohol use disorder. So that umbrella of unhealthy alcohol use spans from at-risk drinking, where people are drinking above these low-risk drinking limits that I have here, all the way to alcohol use disorder, which is when people have developed negative life consequences of their use. And that is diagnosed by the DSM-5 criteria. And I often will bring up this figure actually of low risk drinking limits in the exam room, and it's easily Googleable. But it should be noted that patients oftentimes need to have more individualized goals than what these drinking limits here set out, especially if you're working with people with ALD. There's obviously no known safer use limit. And so we really have to think about individualizing these goals to the patient. But these are sort of for the general population, the low risk drinking limits that are currently issued by the NIH. And those safer drinking limits need to be contextualized using these standard drink amounts of what is actually 1 drink. And there's no universal definition of a standard drink, but in the US, it's defined by these amounts that each contain 14.5 grams of ethanol. So again, I use this all the time as a counseling tool with patients because often we're unaware of actually how much we're drinking. And so we can pull this up in the exam room and really look through these sorts of drink amounts. So as I said, when alcohol use leads to ongoing negative life consequences, it becomes a disorder, or AUD, by the DSM-5 criteria. And having 2 or more symptoms present in a 12-month period meets the criteria for AUD. And then the more symptoms present, the greater the severity. And generally, these questions, these criteria of the DSM-5 fall into a couple of domains of impaired control with alcohol, social impairment, where there's consequences on people's roles, risky use that cause bodily harm or physical, psychological consequences, and then physiological criteria like tolerance, where you're having to drink more to get the same effect, or withdrawal. So let's quickly look at a case to try to apply that. And you can just sort of vote in the chat, or if you're listening, you can think to yourself about what answer you might select. But you have a 40-year-old patient seen at your clinic, and without knowing too much more, here's kind of what they're telling you. They want to cut back on their drinking. They've cut back from 6 to 8 beers a day to 4 beers a day, but they have severe cravings whenever they try to quit, and they're not confident that they can stop. Their family members have expressed concern. They've woken up with hangovers. They've had to miss work. They really increased their drinking during the pandemic, and they're finding like they need to drink even more to get the same effect. But they've never experienced any withdrawal when they've tried to stop or cut back. So thinking about that history, what's the diagnosis here? Is it at-risk drinking, mild, moderate, or severe AUD? And I'll just give you a second. Okay, so let's explore that a little bit more. So when you actually take in whole this patient's history, which is a fairly, common presentation, this patient actually has several criteria from the DSM-5 that they meet, more than 6 criteria, which diagnoses them with a severe alcohol use disorder. And I want to emphasize that we really don't usually have to ask patients these questions in a checklist manner or, go through each of these criteria. in a rote way, oftentimes in an open-ended conversation, you're able to get a sense of many of these criteria from the patient's history. And sometimes it comes out over several visits. And you can revisit how many DSM-5 criteria they meet to see if they have a diagnosis of alcohol use disorder. And it does matter what the diagnosis is because it guides our treatment. So let's talk about treatment for alcohol use disorder. Coming back to this case, here's a little bit more data about this patient's past medical history, their medications, and their lab values in terms of their liver function and their renal function. Take a look at this history, and I'd love people to take a stab at which medication would you recommend for treatment of their AUD. And then we'll explore these different answer choices together. And the main features to take away from this history, additional history, I would say, is their AST of 199, ALT of 100, T-Billy of 2.4, the INR is 1.6, the albumin 3.5, normal creatinine, and an elevated AFP. They're on hydrochlorothiazide for hypertension, pantoprazole, and sertraline for depression. Okay, I don't think we have any votes in the chat, but I hope people have thought through some of the different answer choices here. And so we'll move on. So to think about a patient like this patient, even if they were seen in clinic and screened, would very rarely receive any treatment. And so a study that used National Survey on Drug Use and Health data found that about 80% of people who met the criteria for alcohol use disorder had been seen in healthcare in the previous year. About 70% of those people were asked about their alcohol intake, but only 1 in 10 were encouraged to cut back on their drinking, and only 6% received any form of treatment. So the treatment gap for people with alcohol use disorder is massive. Recent estimates from that same national survey in 2019 showed that 7.6% of patients with AUD got any treatment, and just 1.6% were prescribed a medication, so got pharmacotherapy. And there are disparities in who is prescribed a medication. So for example, VA researchers found a lower prevalence of medication initiation among Black patients. And interestingly, specifically thinking about your population of patients with ALD, in a retrospective study, a very large study of over 93,000 veterans with cirrhotic stage ALD, only 12% of patients received behavioral therapy after diagnosis of AUD, and 1% received behavioral and pharmacotherapy, and only 0.4% received pharmacotherapy alone. So really, this just underlies that perhaps the patients who need treatment the most, those that already have cirrhotic stage ALD, are incredibly unlikely to receive it. Most patients who get an intervention for AUD have received a brief counseling intervention. And when a patient has at-risk drinking, a brief counseling intervention has been found to be effective in a variety of settings. That brief counseling intervention can look like 10 to 15 minutes of first asking permission to raise the subject, talking about drinking behaviors, relating it to problems, perhaps with their liver, eliciting the patient's motivations for change, setting a drinking goal, and really arranging close follow-up. And the tool that I really want to convey to you all about that brief counseling intervention is how to talk to patients actually about safer drinking tips. And there's a fantastic resource from the NIAAA called Rethinking Drinking. The website is on the bottom of this slide, and it has a number of helpful resources to use with patients. It has drink trackers so people can count how many drinks. You can actually use their drink calculators to know how many standard drink sizes you're having. They even have a cocktail counter, and so you can put in custom craft cocktails and see how many standard drinks are in them. They have tools to help patients set goals, find alternatives, identify and avoid triggers. They have tools for counseling people on how to handle urges, and how to build in drink refusal skills. So this is a really great free resource for you to explore with patients. And the brief counseling intervention is great. It has shown to be effective in settings for people with at-risk drinking. But when somebody has an alcohol use disorder that is moderate to severe, like our case that we touched on earlier, they should be offered a medication plus a psychosocial intervention. So next, we're going to focus on the medications for AUD. There are 3 FDA-approved medications and several non-FDA-approved medications that have been studied for AUD treatment. And they have very different mechanisms, but they share several features in common. They are generally very safe and very well-tolerated medications. They have few medication interactions, and with the exception of disulfiram, they are safe if they're combined with alcohol, if somebody is still drinking. And these medicines are really, in fact, easier to manage than many medications we prescribe in medicine. The majority of these can be stopped and started without much titration at all. And they can also be combined with each other. I bolded here on the list the medications that I consider to be more first line based on a number of studies and guidelines. And we're going to move through each of these medicines in a little bit more detail. The first one we're going to discuss is naltrexone. This is often considered the first-line medication. Naltrexone is an orally bioavailable mu-opioid receptor antagonist, and it works by decreasing the reinforcing effects of alcohol. The most robust effects are to reduce heavy drinking, and the number needed to treat is 12. 12 to prevent a return to heavy drinking. The number needed to treat is 20 to prevent any return to drinking or promote a goal of abstinence. So what you can see here is that this medication is effective for a variety of goals. If somebody is actively drinking and their goal is to cut back, or if somebody wants to be completely abstinent. It comes in an oral daily form, which is generally cheap and available. It can be started at a half pill for a week, that's 25 milligrams, and then increased to 50 milligrams. Oftentimes starting at half a pill for a couple of days at the beginning can decrease the mild side effects of nausea or headache or dizziness that sometimes occur. There is actually, interestingly, a trial that came out in this past year that looked at as needed use of oral naltrexone. So using that 50 milligrams when people were experiencing cravings or anticipated cravings or binge drinking, like, for example, before going out to a nightclub or going out to a party. And so that was looked at for people with a more mild AUD or binge drinking, though it's recommended that people would take oral naltrexone on a daily basis if they have moderate to severe AUD. Naltrexone also comes in a monthly intramuscular form that can be injected, and that's a great option for people who don't like taking pills or struggle with adherence. As I said, naltrexone can be used if somebody is actively drinking. It's pretty cheap and available. It can be combined with medications, including gabapentin, which it's been studied in combination with. The biggest issue that you will face is obviously the hepatotoxicity concerns about naltrexone. We're going to delve into that a little bit more because this comes up so often and is an area where we really lack data from trials and really strong evidence to guide us. But essentially, naltrexone at higher doses that were initially used to treat obesity, doses higher than 100 milligrams, higher than are generally used for AUD, initially had a black box warning for hepatotoxicity. And so there have been concerns, particularly about using naltrexone in patients with decompensated liver disease. I'm going to show you a little bit of data to delve into that further, but I often talk about making really individualized choices for patients. So we know that alcohol is very hepatotoxic. And so if there's a patient for whom naltrexone helps to decrease their drinking and decrease their exposure to a known hepatotoxin, I really would consider naltrexone for them. Generally speaking, I think about using the child's PUC or greater as a measure of sort of somebody's compensation and ability to safely get naltrexone. And so if somebody has compensated liver disease, it is safe to use naltrexone. I would reassess for benefit, really make sure somebody's benefiting from it, and also reassess their labs in 1 to 3 months after starting it. As I said, otherwise, there's generally few side effects. Most often is nausea. And it should also be noted that patients who are on opioids, either they're using opioids or they're on an opioid medication for analgesia, should avoid naltrexone because it will precipitate withdrawal since it's an opioid antagonist. I wanted to highlight that even the hepatology and gastroenterology literature, has started to provide guidance on AUD medications and does recommend naltrexone, as I'm discussing here, as a first-line medication that can be used in advanced liver disease, but avoided in those with Child-Pugh class C or greater liver disease. And a recently published retrospective cohort study showed that naltrexone was safe in patients with liver disease, including those with compensated cirrhosis, and it did also include a small number of patients with decompensated cirrhosis. There was a very low incidence of liver enzyme elevation after starting naltrexone. There was no evidence of hepatotoxicity. And I'll talk about it later, but outcomes were actually superior for people who received naltrexone and other medications for AUD. We really do need more data for use in decompensated cirrhotics, but what we have in the available data is encouraging, and generally we have a lot of data to support us to encourage using medications like naltrexone for AUD in patients with liver disease. The next medication is acamprosate. This is the second medication most strongly supported by placebo-controlled clinical trials. Its mechanism of action is a bit unclear, but it's thought to modulate glutamate neurotransmission and some of that hyperactivity that happens with protracted withdrawal after people stop drinking. And it is most effective for patients who have a goal of complete abstinence. And the number needed to treat for that is 12 to prevent any return to drinking. In meta-analyses, acamprosate was not associated with improvement in drinking outcomes in the United States. And so we really haven't been able to replicate findings from European trials. However, the positive acamprosate trials from Europe did lead to it being FDA approved for AUD. And this is an option for people who have advanced liver disease and can't receive naltrexone, or are using opioids and can't receive naltrexone or other medications. Acamprosate does need to be renally dosed. Its most common side effect is diarrhea. Again, this is a medicine that doesn't have a lot of side effects. The main drawback to this medicine is its pill burden. It's 2 pills 3 times a day. So that's really a lot of pills. And the fact that it's really limited to people who have a goal of complete abstinence. The third FDA-approved medication is disulfiram. This is a medicine that inhibits aldehyde dehydrogenase, so it causes that aversive alcohol disulfiram reaction if somebody is going to drink. This is a medicine that I don't prescribe very often because it does have mixed data. The place where it has been found to be most effective is when it's given in supervised administration in like a DOT fashion, which sometimes can happen in a setting like a methadone clinic, for example. So a highly structured environment, or maybe if somebody has a caregiver who can give them the medication every day. But really, this is an unpleasant medication with a very negative incentive. So I've really reserved this for patients who've requested it. Occasionally, there is an individual who's had success with this medication and asks for it. Let's say they're going into a meeting or an event or a trip, and they're really worried about returning to use and kind of use this as a safety blanket. That said, it should not be used in people with concurrent liver disease. So the use of disulfiram is really limited in this population of patients with ALD. We'll move to the non-FDA approved medications for AUD, and the first one is topiramate. Topiramate is a very promising medication for AUD, and actually in recent guidelines from the VA, they have listed it as the first-line option along with naltrexone. In studies, it has a really promising number needed to treat of around 5 for a goal of either abstinence or decreased drinking. The feature that's slightly different about topiramate is it is a medicine that needs to be titrated up slowly, and it also needs to be tapered off if it's going to be stopped. So I have an example titration schedule here. Topiramate is often really beneficial for people who have a concurrent indication for it. Let's say they have seizures, or they're getting treated for obesity, or they have insomnia. There's studies that show that it's particularly useful for people with co-occurring PTSD, for example. However, it does have significant adverse effects when it is usually when it's up titrated too quickly or is at too high of a dose. And those are cognitive impairment, slowing, paresthesias, feeling sedated, appetite suppression. And for that reason, you can sort of use the mantra with topiramate of go low and go slow. So titrate up by about 25 milligrams per week. And you may be able to target a goal of 100 to 200 milligrams per day rather than 300 milligrams per day. And that might be effective for some patients. Topiramate, like acamprosate, also does need to be renally dosed. Next is gabapentin. Gabapentin is so commonly used for people with AUD now. There are several studies that look at it at doses between 300 and 600 milligrams TID, with a number needed to treat of 8 or less. There's one study that shows that gabapentin is particularly useful for people with a history of withdrawal. And it actually can be used for treatment of non-severe withdrawal as well. And it can help with some of the anxiety, sleep disruption, restlessness that people experience in the weeks after they stop drinking. Oftentimes, patients are on gabapentin for another indication, and the dose can be increased for alcohol use disorder treatment. It does need to be dose adjusted for CKD, and it can be combined with other medications for AUD safely. The last medicine we'll talk about is baclofen. This often has been used by hepatologists because of considered safe for use in liver failure and has been included in ASLD guidelines. The data for baclofen is mixed. However, it's not something that I use that often. And there is a very large study from France that treated people with baclofen for AUD and found that it was associated with hospitalization and mortality in a dose-response relationship. So it's very important if we're using this to really check in about, is this medication harming patients, and check in before we make dose increases. So how do we apply all of that information about the medications for AUD to our patient that we used in the case here, in a case of a patient with ALD? And we do have limited data, as I mentioned before, about the safety of these medicines in the setting of liver disease, who are often very medically complex, but increasingly we have some studies to look at to help guide us. And I wanted to point to this large retrospective cohort study of over 9,000 patients with AUD at a single site. This was done at MGH, that they looked at patients over almost 10 years. And in multivariate analyses, they saw that getting a medication for AUD was associated with a decreased incidence of ALD and a lower incidence of hepatic decompensation in patients with cirrhosis. And for patients with ALD, these associations were strongest for naltrexone, gabapentin, and topiramate. And there was a finding that acamprosate, which has a favorable liver profile, as you know, was associated with an increased risk of ALD. This likely has to do with the higher risk patients being chosen for acamprosate treatment. But these results in whole suggest that there's a benefit of naltrexone, which many clinicians avoid using due to the limited data on its hepatotoxicity. And there's also an importance of non-FDA approved medications for patients with ALD. And so if we come back to our case, there's really several medications here that could be considered. Acamprosate could be considered for this patient. Baclofen could be considered. And then, as this study would point to, naltrexone, topiramate, and gabapentin would be my first choice options. I would probably choose naltrexone for this patient, but you have several options. And the way that I think about selecting medicines for AUD is in this kind of summary approach. So I think about the patient's goals. Do they want to reduce drinking, or are they targeting abstinence? In this case, our patient's goal was to reduce drinking. You know, in your particular practice setting with patients with ALD, abstinence is often the goal, and it's more commonly the goal than in a general population. And then think about targeting their comorbidities. So we talked about if a patient has truly decompensated liver disease, you may lean towards acamprosate, gabapentin, or topiramate. If someone's having adherence challenges, you may lean towards extended release naltrexone in a monthly injection. If someone has concurrent opioid use, you're going to avoid naltrexone. If they have concurrent stimulant use, we can talk about this separately, but extended release naltrexone has also been studied for stimulant use, as has topiramate. So those would target 2 different substance use disorders. In the setting of renal disease, you'll need to dose reduce acamprosate and gabapentin and topiramate. And gabapentin might be particularly useful for those with concurrent anxiety, insomnia, or a history of withdrawal. There is also a publication on the management of alcohol use disorder in patients with cirrhosis in the setting of liver transplantation that also comes up with a summary approach. I just wanted to include this here in case you want to reference this later. Okay, so we've gotten through the medications for alcohol use disorder, and I want to bring up how to utilize and apply an alcohol harm reduction approach. And harm reduction is a set of strategies that are aimed at decreasing the negative consequences of alcohol use. And we all meet patients and care for patients that are not necessarily interested in abstinence or ready to stop drinking completely. And so I want to emphasize that we can still support these patients while they are continuing to drink. Total abstinence, it's a high standard for evaluating our clinical success. And it might be that there are several other optimal outcomes for your patient, and those could look like a decrease in the number of drinking days, decrease in the amount of heavy drinking, decreasing in the number of drinks per day, and overall minimizing physical, psychological, financial, and social harm of alcohol use. We know that there's no safe amount of alcohol for people with alcohol-associated liver disease or any liver disease, but there is an increasing literature that shows that reductions in drinking levels and actual grams of ethanol per day is associated with decreased blood pressure, with LFT improvements, with better quality of life, and with medication effects for the medications for AUD that I just talked about. And so talking about reductions for patients if they are not ready for abstinence, it may align better with their goals. It may recognize more of our patients as being successfully treated and encourage us to actually increase our confidence and increase our prescribing of medications. And I wanted to also point out that the National Institute on Alcohol Abuse and Alcoholism, NIAAA, has updated research definitions that are not abstinence-based. So remission from alcohol use disorder is defined by the DSM-5 criteria, just like the diagnosis is. And if a person has not met AUD criteria, except for craving, they're considered to be in remission. It's initial up to the first 3 months, early if it's 3 months to a year, and sustained if it's 1 to 5 years. And so note that this doesn't necessarily mean that somebody has to be abstinent. This means that somebody is not meeting DSM-5 criteria for AUD. And when people are continuing to use alcohol, there's still a lot that we can do for them in terms of providing them with comprehensive care. And that includes making sure that people with AUD have up-to-date cancer screening. We know there's also a synergistic risk with tobacco use, so assess for other substance use, including tobacco. Think about their TB risk. All of the good screening that we do in primary care around IPV, falls, et cetera, should be provided to patients with AUD. We should be reviewing their medications for interactions with alcohol. Those are mostly CNS depressants, and doing early osteoporosis screening, and making sure that people have a good nutritional status, connecting them with resources for food insecurity. We can counsel all of our patients on safer drinking tips, really at any end of the unhealthy alcohol use spectrum. And here are some tools that actually come from a study that I really like, but we can talk to people not just about what they drink or how much they drink, but really how they drink. That means like talking to them about the setting that they drink in. Are they drinking in a safe place? Would they want to drink in a safer way, like maybe alternating with water, alternating with non-alcoholic drinks, counting their drinks, trying to eat before they drink, taking vitamins, spacing out drinks, really avoiding mixing alcohol with other drugs, and focusing on the setting of their drinking as well. You can ask patients questions about how they drink, and it really stimulates a great conversation to really identify tips and safer things that they can be doing. And it oftentimes this shows patients that you're really interested in their well-being overall when you talk to them about harm reduction. So lastly, I want to touch on multidisciplinary collaboration when it comes to treating patients with alcohol-associated liver disease and AUD. There is data that shows that AUD treatment improves ALD outcomes, which makes a lot of sense. And so in this large retrospective cohort study of veterans with cirrhosis who had AUD, any AUD treatment, whether it was behavioral or pharmacological, was associated with a significant reduction in incident hepatic decompensation and long-term all-cause mortality. That's replicated in another retrospective cohort study of veterans with cirrhosis and really high-risk alcohol use disorder. And when medications for AUD were utilized, in this case acamprosate and naltrexone, it was associated with improved survival after adjusting for various confounders like the severity of their liver disease, their age, and their engagement in the healthcare system. And so how are GI or hepatology providers doing with providing medications for AUD, given that we know it's so important to ALD-related outcomes? Well, in a survey of over 400 GI and hepatology providers across the US, over 70% reported that they'd never prescribed any AUD pharmacotherapy. And the most commonly cited barriers to prescribing were a lack of training, unfamiliarity with prescribing, preference for others to manage AUD, and concerns about pharmacotherapy side effects. So I hope that today in this talk, we've tried to address some of those barriers to be able to encourage you and increase prescribing of AUD medications as part of comprehensive ALD care. And there's increasingly models of collaborative care because, as I've said, AUD is at the core of ALD, and it's really something that is not necessarily in the purview of one single discipline. And so there's a real opportunity for collaborative care, integrating mental health services, addiction medicine services, along with hepatology care. Michigan has a model, multidisciplinary ALD clinic that they have published some outcomes for. And they're in their clinic, where they have a mental health provider can currently see patients along with a hepatologist, they found improvements in MELD scores from baseline to 6 months of engagement in their clinic, as well as in hospital utilization, which significantly declined when comparing 6 months before and 6 months after their initial visit. And at UCSF, and some of you may be familiar with this, there is a one-year-old multidisciplinary ALD and AUD clinic that's based at UCSF Parnassus. It launched last January, and over 80 referrals have been seen now. The team members include a hepatologist, that's Dr. Courtney Sherman, an addiction counselor who's Davina Martinez, myself. I joined in this year, started seeing patients in around September for addiction medicine consultation, and we have a medical assistant who serves as a clinic navigator. The target referrals for this particular clinic are patients with alcohol-associated cirrhosis or acute alcohol-associated liver disease, so folks who may have been hospitalized, for example, for alcohol-associated hepatitis, and folks that are not liver transplant candidates. If there are transplant candidates, I am seeing those patients, and they'll be internally referred through the liver transplant program, or I can also always see patients who are being seen at UCSF for hepatology. There are other resources for addiction medicine support within our system, in addition to the HALT clinic, which you can refer to. There is the Bridge Clinic, which is a low-barrier addiction treatment clinic based at San Francisco General Hospital. They do both telehealth and in-person visits, and they also have drop-in hours, Monday, Wednesday, Friday. There's, at UCSF Health, there is a primary care addiction medicine clinic and e-referral that's available. IWork is one of the consultants on the National Clinician Consultation Center Substance Use Warm Line. So if you're outside of the UCSF system or you just want to call Monday through Friday, we'll provide clinician-to-clinician consultation about patient cases or any other questions that come up, and the phone number is there. And then there's inpatient consult services in addiction medicine. For example, at San Francisco General, we have the addiction care team, where we can see patients who are hospitalized, and many of them do have consequences of severe AUD that bring them into the hospital. So in summary, we've talked about the importance of screening all adults for unhealthy alcohol use. using that brief counseling intervention for patients who have at-risk drinking, but for those with more moderate to severe alcohol use disorder, prescribing a medication and offering a medication if a patient's interested. You can select medications for AUD based on the patient's goals and their comorbidities. And treating AUD is really an integral part of ALD care. So I'm really happy that we have increasing forms of collaboration, and I'm happy to take any questions at any point. So that is it for us today.
Great. Thank you so much for that excellent talk, Dr. DeFries. Let's see. I'll wait for any questions to pop up on the chat, but